It is my happy responsibility to begin the proceedings of this colloquium. Today's colloquium is sponsored by the Center for Health and Risk Communication. And I would like now to introduce the director of that center, who will introduce our speaker, Professor Shelley Mann.
I really love to introduce Robert because it feels like I am a really big figure. Anyway, thanks to everyone for coming here today. This is our actually a second CHRC distinguished speaker series. Today's speaker is Dr. Gary Kreps from George Mason University. Just going to do a very brief introduction of him. Dr. Kreps currently is a university distinguished professor and director of the Center for Health and Risk Communication Technology at George Mason. And his research examines health communication, health promotion, social relations, social organization, applied research methods with a major focus on reducing health disparities. His research has been supported by numerous organizations, including NIH and NSF and all those awesome agencies. Dr. Kreps was the founding chief of the Health, Communication, and Informatics Research Branch of the National Cancer Institute from 1999 to 2004, where he planned major national research intervention programs for promoting cancer prevention and control. Dr. Kreps has won many awards, and I believe he pretty much won all the possible awards given in our field of communication. So I'm just going to give you some of the usual suspects. The Louis Donahoe Outstanding Scholar in Health Communication, the NCAIC Outstanding Health Communication Scholar Award, and the NCA Distinguished Applied Communication Scholarship Award. So these are just a few of them among many as well. So ladies and gentlemen, I give you Dr. Gary Kreps.
Thank you very much. I'm really pleased to be here today to proselytize you. It's an opportunity for me to encourage you to think about the ways that the work that you do might relate to health promotion and disease prevention. I've been working in the area of health communication for a long time, since the mid-70s. And back in those days when I talked about health communication, people gave me a very blank stare, like, what are you talking about? What does health and communication have to do with each other? And I'm really pleased that 35, 40 years later, that I don't get that blank stare anymore, that people know what health communication is. Yesterday I had a very interesting 2.5-hour meeting with the chief medical officer for one of the large hospitals in Northern Virginia. He had invited me to come speak with him about health communication and told me how very concerned he was about the quality of communication in his hospital. This hospital is part of a large chain of about 6 big hospitals in Northern Virginia, the Innova healthcare system. And he told me that we had been interacting a little bit electronically by email, and he told me that he had recently met with the medical directors of all of the hospitals, and also the central administration brought up my name, talked about the kind of work I did, and there was general agreement across that they needed a lot of help with health communication. And right now I'm getting ready to propose a big intervention, multi-year research program where we're going to try and use them as a model for developing effective communication, not only between providers and consumers, but also interprofessionally across different people within the healthcare system. And it was such an easy sell for me that I couldn't believe it. I remember 25, 30 years ago meeting with the dean of the School of Medicine at Indiana University, a guy named, I think his name was Buren. He later on went on to become president of Purdue University. And I was a faculty member, and I was trying to encourage him to allow me to maybe teach a course in health communication for physicians. And I remember him looking at me very paternalistically and saying, well, you know, nodding at me, saying, that's very nice. This communication is really a lovely idea, but, you know, our doctors really need biology and chemistry and physiology. The communication stuff will kind of happen by itself. And I tried to persuade him otherwise, but the best I could get him to do is to say that maybe sometime over the summer I could come in and give a guest lecture about communication. He couldn't guarantee anybody would show up, but it wasn't going to happen. And it was the kind of resistance that occurred. And something miraculous happened over the last several years where the physicians, the healthcare administrators, the government agencies have all discovered communication and now recognize how important it is. And so there's a tremendous opportunity, I believe, for members of the communication discipline to really make a difference, to chart the course for better communication. And as I'm sure many of you recognize, the frailty of communication is particularly problematic in the delivery of care and promotion of health. And a lot of what we do in the healthcare system actually ends up making people less healthy and more uncomfortable and doesn't really solve their problems. And it's extremely frustrating. If any of you have had any major healthcare problems or have loved ones who've experienced healthcare problems, I'm sure every one of you here is in that situation. You know how complex and tricky it is to negotiate the modern healthcare system and how non-user friendly that system is. So I think it behooves us as individuals, not even as communication scholars, as regular citizens of the world, to be more cognizant and strategic about the ways that we communicate for our own benefit and for the benefit of the people that we care about. And as communication scholars, we can provide the strategies and the insights and the information to do that work. Now, as a communication scholar, I believe very much in an evidence-based approach to intervention. I'm an interventionist. I like to translate research into practice. And the work I'm going to talk about today is based on the kind of projects I do. I have my own kind of unique, kinky approach to health communication research. It's not for everyone, but it seems to work for me. It's usually based on a pretty intensive period of assessment where I gather a lot of data about what's going on within healthcare contexts, what kinds of issues are being addressed. And this is as true for health promotion as it is for healthcare delivery. What are the nature of the different audiences that we want to reach? What are the nature of the problems? What are the perceptions? What are the past practices? What are the expectations? What's been working? What's not working? What are the opportunities? And then based on that assessment data, I will develop an intervention plan, typically in collaboration with the audiences that I'm working with. I've learned the hard way over the years that it's much better to participate with the people you're working with than to foist your ideas upon them. Because more likely than not, they're not going to be willing to accept your ideas because they're your dumb ideas and not theirs. So the trick is to utilize their ideas, which are usually better anyhow, because they know their system, they know their culture. And then if I can give them some insight and I can help them, we can develop projects together. And then after we do a long period of intervention, development, implementation, and tinkering, usually through the use of formative research and evaluation, we do a larger scale summative evaluation. And so most of my research has that three-part phase of assessment, intervention, and evaluation. And I've been doing a lot of different projects, and some of my projects are at the assessment stage, some of them are at the intervention stage, some of them have already been evaluated. There are different stages, and so I'll try and talk about some of them along the way as I illustrate what I'm doing. Now I'm kind of tethered behind here because I don't have a remote, so I'm not hiding from you, but I gotta make this thing work. This is the hypothesis that guides the work that I do. I ask this question as kind of the overlying question for everything I do. Can health communication help reduce health risks, incidence, morbidity, mortality, and improve quality of life? And I'm really pleased to say that over the years I've gathered a lot of data that suggests that strategic, evidence-based, interactive, and sensitive communication can, in fact, achieve these goals. Now, the issue is how easy is it to develop that strategic, evidence-based, and sensitive communication? Not very easy. And the system is not always very well set up to do that. So there are a lot of impediments and strategies that need to be embarked upon to actually make this happen. So that's what I want to talk about. One of the populations that I'm particularly interested in studying, primarily because of a sense of social justice and empathy and concern, and also because these are the groups that typically suffer from the worst health outcomes. They're the ones that have inequities and disparities in health outcomes, are vulnerable populations, typically people who have very serious healthcare problems, people who are poor, people who are immigrants, people who don't have a lot of the resources, who are marginalized and stigmatized in society. And so a lot of the groups that I work with are in this low resource situation and often need a lot of help and often need a tremendous amount of advocacy. Not only are they not able to often get the health information they need to make good health decisions, their voices are also not very well heard within the system. Given in the U.S. where we have a very profit-driven healthcare system, having resources is a tremendous advantage within the healthcare system. But even those of us who are well-resourced get trampled over by the healthcare system as well. So, although I'm focusing on these populations, I think that the kinds of things I found are relevant for all populations. So one of the things I do is I examine key communication mechanisms and processes, relational coordination, which is a huge problem in healthcare. And not just within the healthcare system, but even within the family. The family, by the way, is the primary site where most healthcare is done. Unfortunately, most families do not have credentialed healthcare professionals there. They don't have the best knowledge. And often they are imparting folk wisdom that may not be the best strategies for dealing with problems. Plus, they don't also often have the time. They don't see themselves as primary healthcare givers. Who do you think the primary healthcare providers are in society? Moms. Moms. And how much training do you think moms get for delivering healthcare? Not enough. And how much support do they get? Not much. And are they doing this on top of a million other things that they need to do? Yes, they are. And are they getting a lot of help from dads and everybody else? Often not. It's really a big problem. And so we need to figure out ways of trying to support members of the family, provide them with relevant information, help encourage them, provide respite when necessary so they can deliver care. I'm very interested in information sharing. I have a very strong information-based approach to health communication. I believe that information is the most powerful resource that you can have in making health decisions. Yet information, good information, relevant information, accurate and appropriate information, timely information is not always available. We thought that the advent of the internet would solve all these problems. There's a ton of information on the internet, and that's exactly the problem. And so it's encouraged, tremendous information overload. And it's also very difficult to determine which is good information, which is bad information, who's telling you this, or somebody trying to sell you something, does this work for you? There's very little quality control. And also there's a problem with a lot of users not being able to make a lot of good decisions about the information available. I'm very interested in issues of literacy. Literacy in general, scientific literacy. There's a real big problem going on in modern society where we're disrespecting science. A lot of people think scientists are bad people. They think science is an evil thing. The governor of Florida recently banned the use of the word climate change. In Florida, where they're really at risk for rising water levels, and they can't use those words because he doesn't believe in the science. I don't think he believes in science at all. And so science literacy is a huge issue. Health literacy is a big issue. Can you communicate effectively in healthcare contexts? And I think because of the intimidating nature of the modern healthcare system, the high focus on technology and medical terminology and sophisticated prognoses and treatments, I think it's even more difficult for people to communicate effectively within the healthcare system. Just finding your way around a major medical center can be extremely trying. I'm interested in social influence and support, and I'd like to put those two things together because I think that not only are we trying to influence people, we're trying to help them. And I think the helping part of healthcare, the caring part of healthcare, often gets trampled in the process of healthcare delivery, and also in the area of health promotion. I think, it's amazing to me how brutal a lot of health promotion is. Somebody somewhere decided that this is what you need to do. No, they didn't ask you. They didn't find out what your issues are, what your concerns, but they're informing you that you better stop smoking, you better stop drinking, you better start doing this. And it's a really, intrusive form of communication, and not particularly persuasive. I don't know about you, but when people start enforcing their regulations on me, I usually have a very negative reaction. Somebody says, you can't do this, typically I'm thinking in my head, I really want to do that. The more they tell me I can do it, the more I want to do it. Why don't they want me to do that? What is back there that they don't want me to see? And so I think that strategy is not very influential, and I don't think it's very supportive. So I think we need to find ways to make health communication more personally relevant, more motivating, and more supportive. I do a lot of tracking communication because I want to find out what people are doing. Where are they getting their health information? What do they know and what do they not know? Who do they trust? What channels of communication do they use? It is amazing to me that people who are doing health promotion efforts often have very little information about that. It's kind of like putting on a show. It's like an Andy Rooney kind of thing, Judy Garland. Let's put on a show. We're going to do a health promotion effort. This sounds good to me. This will be fun. I love this message. Let's send it out. And there's not a lot of previous information about how to do this appropriately. So I'm very interested in tracking and gathering data to guide that intervention work. Testing. I do a lot of testing. I know that intervention in large, complex social systems is not easy to do. It's not likely to be perfect the first time around. In fact, the chances are it's not going to be working very well at all. So I do a lot of effort to try to evaluate what's working and refine over time, and then work with the audiences that I'm trying to help. As I mentioned, I've really focused on information as a critical factor. Providers and consumers are dependent on relevant health information to make informed healthcare decisions. What happens a lot of time in healthcare is that if people don't have the relevant information, they will just not do anything at all. And so let's say you are experiencing a problem, you have a pain, you don't know what it is, you don't know what to do about it, you're not really eager to go to the doctor about it, you'll probably try to ignore it. And that's what many people do. They ignore their healthcare problems until it gets so damn bad, so painful, so frustrating, so debilitating that they actually have to do something about it. Unfortunately, by that time, whatever the problem is probably exacerbated to such a high level that the treatments and interventions have become much more difficult. It's always easier to treat problems early than late. But because the system is not easily approachable, not much fun, expensive, cumbersome, bureaucratic, we're not encouraging a prevention orientation. And in fact, our whole system is extremely reactive. We're much more focused on treatment than on prevention, which doesn't seem to me a very smart thing to do. It seems to me that if we can prevent problems, and we know that about 75% of all major healthcare problems, including cancer, heart disease, are easily preventable through a lot of prevention activities. Or at least you can, hold them off. It would be much better if we focused on prevention. Salient and motivating health information influences health behaviors and can improve outcomes, and there's some good data to demonstrate that. And relevant health information can reduce uncertainty and enhance quality of life. There's a model that I've been using a lot in my research. I don't know how many of you are familiar with Carl Weick's model of organizing. So Carl Weick has a model that's based on information gathering and sense-making, making sense of the world by reducing equivocality. And the reason I like this model is that it's based on interaction. The whole notion is that the more that we interact with people, especially people who have relevant information, the more we can reduce equivocality, the better we are at making choices, and also the smarter we get. the more intelligence we gather for not having to work through these problems again and institutionalizing these decisions for guiding behavior in the past. So I've been trying to build systems, information systems, within healthcare organizations, within clinics, within government agencies, within public health departments, for promoting opportunities to access relevant information and utilize that information for coming up with good rules and guiding the future actions based on those rules. Equivocal nature, I just talked about this. Health information is complex. Many kinds of health risks, unique symptoms, causes, and treatments, changing information environment, new knowledge, new treatment. I mean, every week it seems that they're coming out with a new rule. We just learned recently that cholesterol really isn't that bad for you. Maybe eating eggs is not a bad thing, maybe it's a good thing. For years we were avoiding that. It's very hard to keep up with all the different new prevention strategies. The screening guidelines keep changing. We're not sure exactly what to do about that. And there are significant barriers to disseminating health information, especially for at-risk audiences who often do not have high levels of knowledge, don't have access to all the channels of communication, and don't really understand a lot of the information. And not only that, a lot of the dissemination efforts are not really geared to those audiences. Partly because of the profit nature of the healthcare industry, we're gearing a lot of it to the people who are willing to pay and able to pay. So I study how health information can reduce health inequities. How do you provide information to marginalized populations? How do you overcome misinformation? There's a tremendous amount of misinformation. How do you provide opportunities for members of those populations to share information and to tell people what it is that they're concerned about or what they want? And how do you increase access, understanding, and use of health information so you can reduce health disparities? So let's talk about some of the projects I'm doing. Oh, here's a model. This is I don't know if you've ever seen this model. I like it because it's very colorful. But this is a model of the healthcare continuum. It basically says that in the delivery of healthcare, there are many different pieces. The first part is prevention. As I talked about, I think one of the most crucial pieces of the healthcare system, and prevention is not always well focused on. Then detection, diagnosis, treatment. Treatment gets a lot of attention. Survivorship, we don't think about it very much. And also end-of-life care. The reason I put up this slide is that I believe that communication is essential at each of these phases across the continuum, and often very problematic. So if you're going to focus on prevention, what do you need to do? You want to try to let people know what kinds of things they can do to prevent problems. For example, strategic health communication campaigns. I've been working with public health departments and also the World Health Organization over the last 10 years or more on different strategic campaigns to increase use of vaccination. And as you know, vaccination has become very politicized. There's a fairly vocal, not particularly well informed, but very emotional and very loud audience that says that childhood vaccination can cause autism, can have negative impact. And the people who are arguing this are typically parents who have children who have autism. And it's very hard to discount that information because it's very personal. There are lots of scientists who say, well, that's not really the case. We've got tremendously good evidence that shows that vaccination is not linked to autism, and there are very minimal risks. But they're not nearly as good at communicating these messages. A lot of the parents who are making these arguments are celebrities, have access to lots of channels of communication, are very empathetic, and the scientists who are communicating the information are usually doing it on websites that nobody goes to, presenting their information in a lot of scientific jargon. They're not very empathetic, they're not very interesting, they're kind of dull, and so nobody's paying attention. And so it's amazing how big an effect this has. You know that there's an issue with vaccination, that we need to have a certain majority of the population that gets vaccinated, so everybody benefits from that. And when that percentage drops below a tipping point, a lot of the problems that we are being vaccinated against, things like malaria and polio and all kinds of serious issues start coming back. And many parts of the world, diseases that have been eradicated are not coming back because people are not getting vaccinated. So So that becomes a really interesting issue. How do you change that? How do you reach people and provide them with good information and encourage them to make good decisions? And who are the influencers that can help them? For example, we know that the pediatrician is a very powerful source of information for parents. And while we know that 99% or more of the pediatricians out there really want all the parents that they're serving to get their kids vaccinated, often they are not comfortable advocating for that. They don't want to get in an argument, they don't want to deal with the issues, and they'll just let it go by. And so we need to help those pediatricians become better advocates, more persuasive, more personally involved. How do we work with social networks to encourage people to see the evidence clearly and to make good decisions? How do we use different channels of communication? We were having a big problem at my university, and I suspect here as well, with a lot of undergraduates not thinking that they really needed to get flu shots. A lot of the undergraduates say, well, I'm young, I'm healthy, this is for old people, I'm invulnerable. Yet we have a lot of evidence that some young people who got the flu became seriously ill and some died. And students did not know about that. And so we did an intervention on our campus where we developed a video where students talked about their experiences. They told the narrative, which was very powerful. People understood it. And we showed it at different classes and different settings. And we also made sure, we learned this after a while, that we had nurses available to actually give vaccinations by the end of that session. And almost everybody who didn't get vaccinated signed up and did it right then and there. Because it was salient, it was available, it was easy to do. But nobody tried that strategy before. Health education efforts. We know that HIV prevention and control is a really big issue, and we had done a very good job with it at one point in time. But there's a tremendous amount of recidivism in HIV control. And we haven't been monitoring it very well. And some of the beliefs, public beliefs, particularly with at-risk populations, I don't know if you know this or not, but in Washington, D.C., there's a huge problem with HIV, particularly among African American people. That African Americans in D.C. are as likely to get HIV as in the worst hit countries in Africa. Yet we're not doing a lot about that. And there's a tremendous amount of resistance to communicating about HIV. So I've been working on a project with the National Minority AIDS Council for the last several years of developing community-based strategies for providing good information about AIDS prevention, using members of social networks that are already respected and believed. In the past, they had government people coming out to talk about this, and nobody wanted to hear them. They didn't want to talk to them. And actually, when people, it was just like I was saying before, when people from the government said, you can't do this, a lot of the people said, well, they're stonewalling, they're trying to do something evil to us, they didn't trust them, and it would lead to a boomerang effect. So we tried to use a different approach from bottom up. Behavior change interventions. We're working on a lot of behavior change interventions. I don't know, how many of you know about the 5-a-day for Better Health program? Anybody know what that is? Fruits and vegetables. People think it's all talking about sexual behavior. No, it's not. 5-a-day for Better Health is eating 5 servings of fruits and vegetables every day. It's amazing how few people do that and how difficult it is to get that done. And there's been a lot of effort, there's been a lot of advertising, there's been cooperation with supermarkets, with a variety of other agencies to try and work on this. But it's been a very difficult thing to change because eating patterns are very culturally based. And one of the groups that we were very concerned about were middle-aged and older African-American men who we found from epidemiological research were eating almost no fruits and vegetables at all. And we're very proud of it. They didn't want it. I don't want no steak and vegetables. Get away with me. And so we tried everything we could to get this population. We gave them information. We showed them campaigns. We talked about risk. Totally inoculated those messages. So we started doing some more research about the eating patterns. We found out that very few of these men were actually shopping. Very few of them were actually cooking. Most of them were eating. So we said, who are the people who are doing the shopping and the cooking? And it turned out to be the women in their life, their wives, their mothers, their grandmothers, their daughters. And so we went to them and said, listen, if you want your significant male member of your family to be healthy, you have to change your diet. And they were much more receptive. And we gave cooking classes, we did all kinds of interventions. And we found out that while the men were not particularly happy not to be eating the meat and potato menus that they normally had, they were hungry. And whatever the women put on the table, they would eat. And it actually made a huge change in their eating behavior, increasing dramatically. It was a strategic form of communication. How do you work things so that it works and fits within people's cultures? There's a project I did in inner city DC, in the Anacostia region. There was a neighborhood, primarily African American, very low income, mostly projects, where they had a local park. It became affectionately known in the area as Needle Park because the gangs had taken it over. There were tremendous drug dealings, lots of shootings. Even the cops didn't want to go in this park. None of the parents in the neighborhood would let their kids play in the park. And they were afraid to even have them out in the street, so the kids were having very low levels of physical activity. So we figured, what can we do to change this pattern? How can we encourage the parents to let their kids use the park? And we talked to the parents, and they said, well, make it safe. And so we worked through a coalition of different community organizations, government agencies, the DC Park Service, the DC government, the police department, and some major manufacturers of playground equipment to totally change that park. We, first of all, chased out with the cops all the gangs and the drug dealers. Then we cleaned out thousands of rusty needles and junked up cars and all kinds of stuff out of there. And then we built the park, made it beautiful, and put up lights and equipment. And we were working with members of the community. It totally changed that environment. And not only changed the parents' recommendation that their kids started using the park, which we studied and documented, but it also changed a whole range of health behaviors, and also pride in the community. Made a huge difference from the ground up. It was a real great example of how to apply ecological theory. That if you change the environment and you engage the community, you can make a lot of changes. Unfortunately, there's not a lot of work we've done. There's a tremendous amount of effort going on now with tobacco cessation. And I'm really concerned that there's a tremendous amount of recidivism in terms of tobacco, particularly among young people. You probably see a lot of your undergraduates around campus smoking cigarettes. And the e-cigarettes have become a really big problem as well. How do we deal with this issue? How do we provide messages and support that will be appropriate and motivating? I think we need to work with those audiences. And unfortunately, a lot of the federal agencies, including the FDA, I don't think have been coming up with very strategic messages. They're coming up with big, one-size-fits-all strategies that I think only work with certain segments of the population, and often not with the ones that are most hard effective. How to communicate disease detection information effectively. Most diseases can be treated effectively and detected early, so you need to encourage screening. How do you encourage screening? I've been doing a lot of work with Korean American immigrants in Northern Virginia. I know in Maryland we also have a large Korean American immigrant population. There's a very high rate of cancer, not only in terms of incidence, but also in terms of mortality. And part of the problem is that a lot of the Korean Americans don't like going to the doctors here because they don't feel very comfortable. A lot of the Korean Americans, because it's a very insular society, don't speak English very well. And most of the doctors don't speak Korean. And a lot of Korean Americans who we interacted with and interviewed, we found out were waiting until they went back to South Korea to get health care. And maybe they only did that once every 4 years. So waiting 4 years to get screening if you have the notion that you may have a problem can be very dangerous, especially if it's a fast-moving cancer. And even if they go back to Korea, they get detected, typically they're only staying there for a week or two. They're not likely they're going to get treatment. So they get the diagnosis, they come back, and they don't do anything about it. So it's a huge problem. And there's a lot of different factors involved. There's a very limited information environment. And we found out that a lot of the Korean American immigrants are getting a lot of their health information from periodicals, Korean language periodicals, many of them from Korea. And there's very little coverage of the health issues, very little connection to the healthcare system here. And the healthcare system here has not been very supportive. So to do interventions, we needed to make a lot of changes in the way information was disseminated. We had to change the ways that Korean Americans got health insurance. A lot of Korean Americans have small businesses in the U.S. They run nail shops, and they have restaurants, and they have different small businesses. And because they're independent businesses, it's very expensive for them to get health insurance. They don't have like a big group plan. They're not part of IBM or the University of Maryland or some other group that's negotiating for them. And so one of the things we try to do is to band together people in the community to create a insurance collective so they can get lower rates and get insurance. And let them know why that was important. We also tried to we found out that the second generation Korean Americans were very good English speakers, but the parents and the first generation were not. And so we tried to use a lot more intergenerational communication, encouraging the kids to go with their parents to the doctor and to help them understand what was going on. And through a variety of interventions, we're actually right now in the intervention stage in this research. We have a ton of data showing the problems. We went back to Korea and we collected some of this data with a translated form of the Health Information National Trend Survey. Do you know about HINTS? How many people know what HINTS is? About 5% of you. HINTS is a large national survey that I started when I was at the National Cancer Institute many years ago. It's been conducted by NCI every other year for the last 12 to 15 years. And it finds out what people know, what they don't know, what information gaps they have, where they get the health information, what sources they prefer, and also identify strategies for intervention that can be geographically localized so we can provide specific information. It's become a really big opportunity for a lot of people to do secondary analysis of data because NCI makes the HINTS data easily available. But one of the big problems is that a lot of the marginalized groups are not well represented within this representative sample, especially people who don't speak English very well. They do HINTS in English and Spanish. That doesn't really help the Korean Americans who are not speaking either of those languages very well. And so they're not very well represented. So one of the things I've been trying to do is to translate HINTS research and questionnaire into different languages, in Spanish for different groups, in Chinese, and also in Korean. We've been conducting that research. We went back to Korea to see whether or not the information gaps that we identified here in the U.S. also existed in Korea. We didn't know if this was kind of an indigenous issue, but it was not. It turns out that immigration itself has a huge negative impact on information dissemination, health promotion, and prevention. And so we need to really focus on immigrant groups to try to do a better job. And I think we need to do a better job of monitoring knowledge use and screening programs. And that's one of the things we do with HINTS in the U.S. And right now we are in the field in China doing a national dissemination of the HINTS research program to 100,000 Chinese across the entire country. And we'll be developing a lot of targeted intervention programs there over the next several years. How do you communicate diagnostic information effectively? I was amazed how often in the research I've been doing about medication adherence, you know, about half of the people who are prescribed medications don't take it, even people with chronic diseases. And we want to know why they weren't taking it. We found out that the major reason people didn't take their medication is they didn't really understand what they had, they didn't understand why they needed this medication, and they didn't really have a lot of confidence it was going to help them. The second reason they didn't take it is that they didn't like the way they felt when they took the medication. They didn't want to take medication, and they didn't really know what to do about it. And then the third reason was that they didn't like the cost of the medications. But obviously this is an information issue, and nobody was really providing them information about the nature of their diagnosis. We had people who had diabetes say, well, I have a little sugar in my blood, but nothing to worry about. We had people say, I used to be diabetic, but I took my medicine for a couple of weeks and feel really good, and I don't even do it anymore. Not realizing this is a long-term disease. It's not going away. Nobody really explained this to them. And the same thing is true for a whole wide range of health problems. So how do we provide better diagnostic information? One of the projects I'm working on right now is people who have rare diseases. People who have rare diseases have a lot of problems because it's not easy to diagnose their problems. It's not easy for providers to explain. And a lot of times they don't explain. In fact, we found out recently, there was an interesting article that about 75% of the people or more who have Alzheimer's disease never get told by their doctors. Because there's no really definitive biomarker for Alzheimer's disease, and the doctors don't know what to say about it, they don't want to give the bad news. I've been doing some research with the Veterans Administration, with cardiologists. Found out that cardiologists have what they call an optimistic bias. They really don't want to tell their patients who are dying that they're dying. So they usually assume that they're going to get better. Why would they want to tell them? Because it's not comfortable. They don't like it. They're not, they don't want to get them upset. They don't want to get themselves upset. Because they don't talk about it, people are not getting prepared. People who are likely to die within the next 3 or 4 weeks don't know that they're dying. Either they're getting better. Don't get referred to hospice care. And so it's a huge problem. So we need to find out ways to deliver good diagnostic information. If people don't know what their problems are, they don't know what the different solutions are, they don't really have informed consent. They don't know what to do. And informed consent is routinely trampled in healthcare. Informed consent is supposed to let you know what all your options are, what the shortfalls are, let you make good decisions. Typically in healthcare, informed consent is the doctor saying, we need to do this, we need to do it right away, sign here. That's not informed consent. And because of that, people don't really understand, and they're not making their best decisions. So we need to accurately interpret diagnostic information, and we need to deliver diagnoses meaningfully. Treatment information. We do a lot of study of treatment information, but there's still a tremendous amount of misinformation. A lot of people think of themselves as like, going to bringing their car in to get fixed, or when they go to the doctor, they think it's like a TV, you're going to replace a part. They don't realize how uncertain and probabilistic and creative therapy is. That most therapies are based on precedent, and because you're different from a lot of those other people and have different backgrounds, different hereditary factors, different lifestyle factors, you're not likely to respond exactly the way those other people did. So we need to kind of refine treatments over time, usually through trial and error, which means there needs to be very active communication between doctors and patients so they can figure out how things are working, what's not working, how can you change it, how can you update it. Yet that's not really happening. A lot of times you get the diagnosis, you get the treatment, and you're stuck with it whether it works or not. With not a lot of refinement. So what we need to do is develop a lot more relational updating and coordinating and communicating and sharing of information. And this is not just a doctor problem, it's also a patient problem. Even the patients who are taking medications that are not working, they don't really want to talk to the doctor about it, they don't want to tell them. So they just say, I'm not going to take it anymore. Or not take as much of it. And that's not obviously going to help them either. So we need to encourage better communication from the bottom up, from the consumer, and then from the top down as well. Survivorship. We've been doing really well with a number of diseases, particularly heart disease and cancer, whether you know it or not. But there are a lot of survivors. There are more than 3 million cancer survivors in the United States nowadays, which is huge. Unfortunately, those people who are survivors have huge problems. Cancer treatment is very invasive, causes a lot of problems, and those people who have had cancer before, even though the cancer may be in remission now, are at great risk for the cancer coming back, at greater risk than anybody getting cancer for the first time. And we're not doing a very good job of supporting those people, helping them deal with their side effects, which I think are many times main effects. We have a whole long list of side effects, nausea, depression, pain, impotence, huge problems that have a huge effect on your life, yet we're not doing a lot to help those people. So a lot of people who may be survivors are not living very happy lives. Their overall well-being is not very high. And they're not getting the support they need. One of the biggest problems is uncertainty and the fear of reoccurrence. And so I think one of the things that we can do is to connect people. And one of the areas I've been studying is online support systems. I'm really a big believer in online peer support because you can connect people with others who have exactly the kinds of issues they have and provide them with the information needs that is relevant to them 24/7 whenever they need it. And this year at the DC Health Communication Conference in 2 weeks, we're going to be honoring Jill Friedman, who is the founder of ACOR, the Association for Cancer Online Resources, which is the largest international network of cancer online support groups with more than 80 groups that are operating all around the world that provide tremendous support and information for people. And then the life care. We talked already about the cardiologist issue. We have a tremendous stigma about death in our society. We don't want to talk about it. Yet there's tremendous uncertainty and fear and problems, and a lot of people who are long time grieving because they were not really able to reconcile with family members or other ones they care about before they died. Doctors feel really uptight about it. They don't want to talk about it. A lot of people who should be in hospice are not there. So it's a huge issue we need to open up and communicate. One of the things that we really focus on are difficult topics of communication in healthcare. Transitions from active care to end-of-life care. Oftentimes, the doctors are not really that eager to tell you that there's nothing more we can do for you. There's no more treatment. So what ends up happening a lot of times is people keep getting treatments that doctors know are not going to help. And many times those treatments can be very debilitating, like major surgery, or chemotherapy, or radiation therapy, or other forms of care that can cause a lot of problems. So we need to be able to address these issues, to make good decisions, to improve whatever span of life you have left, you want it to be of high quality. Palliative care is a huge issue. I believe that palliative care, which is care to reduce pain and suffering, is as much a communication issue as it is a pharmacological issue. Yet typically the way it's treated is only through pharmacology. And a lot of times the pharmacology is like hitting somebody over the head with a hammer. It's like you're out. And when you're out, you're not really dealing with people. You're not really solving your problems. You're not really addressing issues. And it doesn't really give people a sense of efficacy that they can control their pain and their suffering. And so I've been doing a lot of work with use of communication strategies to help people understand and chart their episodes of pain and identify ways that they can get help and try to promote greater coordination in delivery of palliative care. And I think that providing support and comfort through care coordination is really a critical issue. One of the big projects I did with the Veterans Administration was we put little boxes, little called Health Buddy computer boxes in the homes of veterans who were getting chemotherapy. And every day the veteran would check in, and they had different biometric readings that they would give about their blood pressure, and they would give other reports about how they were doing. And this was automatically charted by the central VA. Whenever a veteran who was getting chemotherapy would go beyond the barriers, the parameters for good health, it would alert a nurse to call and say, how are you doing? And provide intervention. Oftentimes the intervention is just telling the person what they need to do, helping the caregiver, but sometimes it involves sending a doctor out or sending them into the hospital. But it made a huge difference in the quality of their life because they were getting good information and care on a continuous basis. And most healthcare is not continuous, it's very episodic. So we need to find ways of continuing. And I'm extremely excited about the use of health informatics as a way of supplementing the person-to-person communication that we typically do in healthcare to provide access to information and support whenever you need it and wherever you are. I'm very excited about mobile health as a technique and strategy, not only for healthcare but also for health promotion. How many of you have Fitbits in your wearing? Not that many, okay? But it's becoming a pretty pervasive part of society. It's amazing how ubiquitous. Sometimes I ask my question and everybody in the room raises their hand. It's kind of a dumb technology because it just gives you very limited information. But I think in the future we'll have personal health assistants that will give us a lot of information, encouragement, tell us when we need to take our medication, advise us about making choices in the grocery store or the restaurant, will help us, engage in exercise, do things that will keep us healthy. The trick will be in terms of trying to design these systems to be humane and easy for people to use and fun, and not, another boss telling you what to do. So here's my intervention process, and I'm coming to the end. I start with assessment. I do all kinds of audience analysis research. I also recruit partners to work with me, usually at this stage. I do a whole range of both quantitative and qualitative methods. I'm a real big believer in triangulation. Then based on those data, I try to design interventions and then implement those interventions. I do a lot of formative evaluation. This is all basically a research process. And then we do a formative evaluation, a summative evaluation, a formal large-scale evaluation, usually experimental, field experimental research. where I'm trying to use some of the data that I gathered early on in the assessment phase and then gather the same data later on as outcome data to determine whether or not the intervention made a difference. It's usually pretty strong. I try to include both physiological and cognitive and behavioral measures. So I'm not just looking at whether people feel better or have changed attitudes, but also whether their physiology has changed and whether they're now engaging in behaviors they want them to do. And there's some very good evidence that strategic communication interventions can make a big difference. This is my big closing slide. You guys are excited about this. This is a model that the Canadian Cancer Society developed about 20 years ago, but it's a beautiful one that talks about how different research activities connect with each other. You start off with fundamental research. What do we know about the communication process? What do we know about health behavior? We move to surveillance research. What are people actually doing? What do they know? What do they not know? What do they believe? How do they want to get their information? Based on that fundamental and surveillance research, we develop interventions and we test strategies for addressing these issues. And through a knowledge synthesis, we end up with new applications and program delivery. I love this model because it integrates all different aspects of communication, from basic, theoretically geared research to more applied research to surveillance research. How do we connect all that together to really make a difference and translate that into practice? And I think that it can reduce different health burdens. So my health communication research goals, this is what I'm trying to do. Develop the infrastructure for rapid advances in knowledge about health communication. Test new communication strategies, models, and tools. Disseminate relevant information to key audiences. Implement the best health communication practices, something the former director of NCI, Andy Vaneshebach, called discovery, development, and delivery. I think if we do that, we can make a big difference. And I encourage you to think about ways that you contribute to promoting health through communication research. Thank you very much. I have a few minutes. If you have any questions, I'm very happy to answer.
Questions from the audience.
Yes.
Gary, what have you got going in D&I or dissemination implementation? Where do you see that fitting into your research program?
Well, it's a huge part of it. Usually that's a big piece of the implementation phase when I do an intervention. Often when I can identify, for example, the work that we're doing in the US and China with HINTS is based to identify information gaps. When we identify those information gaps, especially if there's serious misinformation, the next step is to come up with strategies for disseminating better information so we can guide more informed decision making. The trick is that you can't do dissemination the same way for every audience. Every audience has different issues, so it has to be very targeted. And a lot of people who do health promotion, I do a lot of work with the CDC, helping them plan interventions. They always want to do the same intervention strategy. They always want to do pamphlets. I love pamphlets. But you know, that may work with one audience, but not very much with another. So you've got to really have targeted on-the-ground communication. Yes?
So a big theme of your research seems to be working with these vulnerable populations and the communities that they reside in, so we can have more tailored communication. What are your strategies for figuring out what community organizations will be most effective in the implementation?
I'm a real big believer in epidemiological research. There's a tremendous amount of research out there that shows who are the people who are suffering the most from different health problems, who are the people who have the highest mortality rates. Usually those are the vulnerable populations. So I allow the data to demand and need and problems to guide the work I do. It's kind of like, low-hanging fruit. I see that these are real problems. Why? Why are they having these problems? And what can be done? And what are the communication dimensions of those problems?
So my second part of the question is, how do you figure out, so in the example of the Korean immigrants, how do you figure out which community partners you're going to work with? Or in the PART study, what strategies do you implement to get these community partners on board?
Usually in the very early stages when I do some of the audience analysis research, I'll go into the community and I'll start conducting interviews. Usually I start off with observations. I'll just observe. I'll find some cultural informants, people in the community who are concerned about this issue already, who may be serving that audience, who will help me, and they'll connect me with other people. And often the people I talk to, especially when I tell them I want to help them address these issues, they express interest in helping me and becoming my partner, and I enlist them. Hardly ever do these people get paid, but they want to be part of it. So with the National Minority AIDS Council project, we had community liaisons in urban areas around the United States. None of these people got paid for the work, but they really were committed to trying to change the trajectory of HIV infection in their communities, and they were making a huge difference.
Here's a strange question for you. Is there any flock that you had that you learned from tremendously in terms of how to read, how to go about doing something?
Yes, I've screwed up a lot.
I'm talking about health communication.
Yeah, there's an old adage in management literature that the best leaders are the ones that make the most mistakes. The trick is not to keep making the same mistakes over again. But one of the things I've learned early on is I used to think I was the expert. I used to think I knew it all. And I was going into these communities, I was going to tell people what to do, I was going to enlighten them. And I learned pretty quick that most of the people were not that eager for me to tell them what to do. And often of that, I did not understand their culture or what the issues were, and I'm giving them really stupid advice. So I learned really to do a kind of a community-based approach where I invest in members of the community that help me design and implement and evaluate what we're doing. That has been a strong message for me.
Let me kind of turn that around. It seems to me there's an assumption over all of this that one should make one's own healthcare decisions. And that's probably a value judgment. But it strikes me that in vulnerable populations, that there's some pragmatic implications to it. That often, the healthcare system is just saturated with authority structures and all kinds of symbols of that authority structure. And so when you're in a vulnerable population and you fall into it, they're practically begging you to grant authority to all of this authority that's around you. And in addition, a lot of these people are vulnerable because they may not be able to make decisions by themselves in a way that we would say, oh, those are good decisions. So that basic assumption that you ought to do your own health care, you question that, do you?
Yeah, I think that the ability is a really pretty good. Earlier I talked about biological literacy and scientific literacy. If you don't have much biological literacy or science, it's very hard to make good decisions. So I think one of the issues is raising that literacy level and also providing information and support. I've become a pretty active member of an organization called the Society for Participative Medicine. It's pretty new, about 2 or 3 years old, and this is kind of a renegade organization of angry consumers, radical providers, and social scientists who kind of band together to find ways of promoting collaboration in making health decisions. And their rallying cry is, give me my damn data. Because they find out in healthcare that consumers often don't have access to their own health data. And without that, they can't make good decisions. But I really think that's that collaboration. I'm not saying that people should just go and do whatever they want, because that may not be very helpful for them. But I think they should be getting better information for making more informed choices. And I'd like to help people do that. And if they can, sometimes when you're really sick, for example, if you're unconscious, you're not making a lot of active decisions, but your family members may be. And they're the ones that need to be engaged. I don't know if that helps or not.
Can you talk a little bit more about the online support groups? Because I'm working with Children's National Medical Center. We are working with youth there on promoting health, and we have used online support groups, but we feel like we need to have a professional in that support group 24/7 because, like you said, they're getting all this information and there's no one there to sort of supervise.
Yeah, the ACOR groups, the Association for Cancer Online Resources, are all moderated groups. So there is a moderator who is an expert who helps to maintain discussion and keep people from, killing each other, if there's wrong information. We find that in these groups, however, that the people who have the unique healthcare problems are extremely knowledgeable about those problems, often more knowledgeable than their providers who deal with a whole range of health problems. And if somebody gives wrong information, they get jumped on very quickly. So the quality of information is pretty high. But there is a moderator in those groups. By the way, I love Children's National Medical Center. My son works there in the psychiatric, adolescent psychiatric group. Got his degree here at Maryland.
Okay, I think we have bypassed one, so we will thank Dr. Kreps again for delivering this very.
Well, I think I have one more slide that says all the references. If you want these, hopefully it's in key references. If you want to look at it and stuff up, see if I'm telling the truth.